Hello, I'm John Bell. I'm a consultant in anaesthetics and intensive care medicine in the Peritoneal Malignancy Institute in Basingstoke. I've just given a talk on the anaesthetic considerations for cytoreductive surgery, just to summarise the things that I covered in that talk. So I talked about the pre-operative, the intraoperative and the post-operative considerations for this surgery. When I was talking about the pre-operative considerations, I spoke about the impact of the patient's disease, their peritoneal malignancy, on their current health status. So I talked about the impact of the abdominal distension, so that might be causing aortocaudal compression, it might be causing respiratory compromise due to the diaphragms being pushed up from disease within the abdomen. Certainly often it causes problems with nutrition, causes gastrointestinal reflux. Sometimes the patients present to us with intestinal obstruction. Occasionally we have patients presenting in a more urgent fashion due to bowel obstruction. They might have perforation or sepsis and abscess within the abdomen. The other thing that other factors that I would be looking into in pre-operatively assessing patients is their pre-existing health status prior to the development of their peritoneal disease. They may have pre-existing cardiovascular or respiratory disease, and I'd be interested to know whether that had been effectively treated and optimised to reduce their perioperative risk. The other elements of the pre-operative care and assessment of this patient group for me as an anaesthetist is to make sure the patients are aware of what is involved in the anaesthetic and the surgery, to reassure them and answer any questions or concerns they may have. Normally at this point also I'd be addressing whether or not there is any need for any pre-medication, be that sedative, pain relief or anti-reflux medication. And then progress to talk about the intraoperative care of these patients. I spoke about the preparation of the patient in the anaesthetic room, which required the placement of a number of pieces of equipment so that the patients would have peripheral venous cannulae and an arterial cannula. They would, after going off to sleep, have an endotracheal tube and a nasogastric tube placed. They'd have an epidural catheter, they'd have a urinary catheter, and that whole process tends to take around about 45 minutes to an hour or so in the anaesthetic room. Once all of the equipment has been placed, they're transferred into the operating theatre. A lot of time is spent making sure the position of the patient is optimal to reduce the risk of pressure areas, to reduce the risk of neuropraxia, so brachial plexus injuries from the arms being overextended, and to apply warming blankets to allow us to warm the patient throughout the operation. After the operation has started, the problems that we often have to deal with are fluid losses requiring large volumes of fluid administration. This is guided by monitoring and cardiac output monitoring in theatre. We have to deal with heat loss through a large abdominal incision, requiring heat application through hot air blankets, up until the point of chemotherapy, when we tend to have the reverse problem that the patients are warmed up by the chemotherapy and often become pyrexial, and we have to actively cool them down. Patients often develop a coagulopathy intraoperatively, requiring frequent blood testing and use of blood products to treat that. The operations can be long. There are sometimes problems with staff fatigue. We make sure we have a team that can work together to allow people to have breaks and stay fresh throughout the case. At the end of the case, the majority of patients are transferred to the intensive care ward, and they're transferred there sedated and handed over to the care in the intensive care team. Often they remain intubated, ventilated and sedated overnight and are woken up the following morning, although with shorter cases we certainly consider waking them up either at the end of surgery or soon after their arrival in the intensive care unit. The ongoing care in intensive care follows the similar themes to the care in theatre, so fluid management, correction of coagulopathy, analgesia and care of pressure areas. After the patients wake up, one of the primary problems we have to deal with in anaesthetics is the pain management. This is difficult for many of the patients that have a large abdominal incision. They often have chest drains as well. Tend to use a combination of epidural anaesthesia and a patient-controlled analgesic pump. The combination of those two mechanisms tend to mean that patients remain comfortable, but we are seeing a number of patients who have problems with hallucinations, delusions and agitations post-operatively. So we are still trying to improve our pain relief for these patients post-operatively. Much of the learning for this patient group has come from experience within Basingstoke, but we also have been interacting with the worldwide community involved in this kind of surgery, just to make sure that we are giving the best care to this patient group that we can.